Hi, my name is Bethany, and I'm a nursing student at the University of Michigan. I'm going to present one of my clinical patients to you. Patient is an 89-year-old married Caucasian male. Former occupation was in law enforcement, and patient is currently retired. His usual source of medical care is at St. Joseph Mercy Hospital. Patient was admitted at Heartland June 5, 2013 after being transferred from St. Joseph Mercy Hospital, where he was admitted for a fractured acetabulum. Patient stated that he was taking out the garbage when he backed up and tripped on the recycling bin, causing him to fall. He fell onto his left hip on the pavement and also hit his head and left elbow. Patient currently rates pain at a 0 while he was lying still, but says it rates at a 10 when he is being repositioned. He experiences pain in his left hip all the way down to his foot. Patient states that he gets uncomfortable and his butt gets sore after being in the same position for too long. Pain medications and rest help alleviate the pain. Patient is currently undergoing physical therapy for his upper body to keep him moving and strong. Patient is eager to start physical therapy on the lower extremities and begin walking again. Vital signs were stable according to patient's chart. Blood pressure was 128/78, pulse was 66, and respirations were 18. Past medical history. Patient has a history of hypertension, depression, coronary artery disease, Brady-Tachy syndrome, subdural hematoma, cerebellar degeneration, hyperlipidemia, systolic and diastolic congestive heart failure, deep vein thrombosis prophylaxis, and bladder cancer and kyphoplasty. Patient is up to date on immunizations. Allergies include Tylenol, codeine, and contrast dye. Hospitalizations and surgery. Patient has a right glass eye after trauma received 11 years ago. Treatment was attempted, but his vision was not regained. Patient had a CABG procedure, quadruple bypass, and a pacemaker implanted after complaints of shortness of breath led them to find a blocked artery. Patient had pneumonia in October and gout in his right knee that he had surgery to remove. Years ago, he had a break in his left arm that required 28 screws and 3 plates. Patient states that it is fully functional. Current medications. Patient is on multiple pain medications including morphine through an IV, multiple stool softeners, Xyloprim for the gout, Zocor for hyperlipidemia, eye drops in his right eye, which is his glass eye, heparin subcutaneously, Zofran and promethazine for prevention of nausea and vomiting. Patient is also on Celexa, Xanax, and Lexapro for depression. Patient's Vasotec for hypertension was suspended. Functional assessment. Patient denies the use of alcohol, drugs, or smoking and states that he did smoke and drink at one time, but only socially. Patient is not currently able to ambulate and denies any recent exercise before the fracture. Patient did state that he used to walk 5 miles every night with his wife and does have plans to begin exercising once he can walk again. Patient does drink caffeine in the form of coffee. Patient stated that he uses a cane around the house when he feels the need for extra support. Wheelchair was noted in his chart but not observed in his room. Psychosocial data. Patient is Finnish and very active in cultural activities. Patient does have spiritual beliefs and identifies himself as a Lutheran. Patient is active in social groups and enjoys helping set up for meetings and activities. He visits his wife daily at Heartland, and she has been there for a year due to fungal meningitis. She is down the hall, and he makes sure he doesn't miss a day. He talks openly about her condition, but stated that he does experience anxiety when both of their health begins to decline. Together, they have 4 sons, 2 daughters, 12 grandchildren, and 12 great-grandchildren, with 2 on the way. He seems very close and involved with his family. Family history. His father died of a heart attack at the age of 49. Mother also died of heart-related issues in 1963. Chart states a history of breast cancer and colitis in the family. Review of systems, musculoskeletal. Given the patient's recent hip fracture and non-ambulatory state, it is important to assess the musculoskeletal system. Patient denies any joint pain, swelling, redness, warmth, or deformity in all joints except for the left hip. Due to the fracture, he does note swelling, bruising, and pain in the left hip. Patient does admit to limitations in the range of motion, but all are related to hip fracture. He denies any other limitations. Patient is experiencing difficulties in performing daily activities due to immobility and requires some help with most of his ADLs. Patient is unable to ambulate due only to the hip fracture. Patient does report weakness in his left side from the hip down to his foot. No history of arthritis was noted. Upon inspection, muscle mass appeared symmetrical. There was obvious bruising around the left hip from recent trauma, as well as bruising on his left temple and left elbow, also from the fall. I was unable to assess the patient's gait due to immobility. Posture was straight and balanced when sitting by lifting the head of the bed. Patient had full range of motion in the TMJ, neck, shoulders, and elbow. Patient was unable to fully hyperextend wrists, but was able to perform flexion, extension, inversion, and eversion. Patient did not have full range of motion in left ring finger due to his ring being too tight. All other fingers did have full range of motion. We were unable to test his hips for range of motion due to recent fracture. We did test the right knee, and full range of motion was noted. Ankles were stiff, and patient was unable to fully demonstrate extension, flexion, inversion, or eversion. Unable to assess range of motion in spine due to inability to ambulate. Strength in upper body was assessed and graded as a 5 out of 5. Peripheral vascular. This system was assessed due to the patient's recent musculoskeletal trauma. Patient denies any pain other than that on his left side from the hip down to his foot. Pain is worse when repositioning. Patient denies any edema or hair loss on extremities. Patient does report having cold hands most of the time. There is no history of blood clots in his legs or varicose veins. Upon inspection, no edema was observed in the lower extremities. No cyanosis or erythema in hands or feet. Hair distribution appeared normal and no varicosities were observed. Palpation indicated colder hands and feet compared with the rest of the body. We also felt it important to note that when palpating his chest for cardiovascular, the left side of his chest was noticeably cooled to the touch. No tenderness, excess warmth, or edema was palpated. Pulses were as followed: temporal +2, carotid +1, brachial +2 on the right but +1 on the left, radial +1, femoral +1, popliteal we were unable to palpate, posterior tibial +1, and dorsalis pedis +1. Some of the pulses did feel slightly weaker on the left side when compared to the right, especially in the lower extremities. Capillary refill was normal at 2 seconds. Pertinent system 1, respiratory. Patient was diagnosed with pneumonia this past October. Given his state of immobility and other chronic conditions, it is important to perform respiratory assessments often to check for any signs of pneumonia or respiratory distress. An article released by the American Journal of Medicine considers risk factors for pneumonia in the elderly. According to official statistics in the United States and Finland, pneumonia and influenza are among the 5 leading causes of death in people aged 65 years and older. Certain chronic diseases, especially those of the cardiovascular system and the lungs, are generally regarded as predisposing factors for pneumonia because of their frequent occurrence in affected patients. Given the patient's history of cardiac disease, it is important to monitor him for any respiratory changes to prevent or quickly treat any community-acquired pneumonia. Pertinent system 2, integument. Given the patient's inability to ambulate and the limited ways to position the patient due to his hip fracture, it is important to find ways to prevent skin breakdown and the formation of pressure ulcers. In an article released by the International Journal of Tissue Repair and Regeneration, risk factors for pressure ulcers were explored among elderly hip fracture patients. Patients with hip injury have ample opportunity to experience periods of immobility of 2 hours or more. This can be from the time they fell, depending on how long they had to lay there, all the way to the time they spend in a hospital bed. The study showed that the incidence of pressure ulcers among elderly hip fracture patients ranged from 10.2% to 66%. This large range varied based largely on the time period and pressure ulcer definition. A main conclusion did state that their findings supported the clinically accepted notion that skin breakdown can be initiated after only 2 hours of immobility.